I'm Dr. Barbara Ganzel. I'm a hospice-trained social worker, a research neuroscientist, and I've been working and publishing on the effects of psychological trauma on the mind, brain, and body for more than 20 years. My full bio is at the end of this presentation. I'll be talking today about trauma triggers and an approach to addressing them through universal, trauma-specific, and person-specific precautions. This is an important step beyond universal precautions for trauma-informed care. My good colleague, Paige Hector, and I have created a 10-part video series on implementing trauma-informed care in long-term care. This is the fourth of that series. Here's the topics for today. We'll start with the CMS Final Rule on trauma-informed care and work our way down to person-specific trauma precautions. Phase 3 of the CMS Final Rule for long-term care organizations required the implementation of trauma-informed care in long-term care. This went into effect in November 2019, but we had a pandemic. Once the COVID-19 pandemic subsides, CMS will return to enforcement. The CMS Final Rule says that trauma-informed care is an essential part of person-centered care. We note that the final rule also points to SAMHSA's, the Substance Abuse and Mental Health Services Administration's, concept of trauma and guidance for a trauma-informed approach as the way forward. So, if you're doing long-term care, this is the model that CMS is pointing you towards using. Here's the concept of trauma and guidance for trauma-informed care. Here is the tip 57, which is the expansion of how you apply this concept of trauma-informed care and how to do trauma-informed care and this is for the behavioral health services. Now, applying this to long-term care and medical type settings is going to be a little bit different, and we'll talk about that in this video. So there's been a dynamic new consulting industry that has arisen to provide behavioral health services in long-term care since the implementation of phase 2 requirement for behavioral health care to residents. The industry is now going to have to adapt to providing trauma-specific services and treatment for trauma survivors in long-term care. That is part of phase 3 now. Treatment may have somewhat different goals of care in these settings, but lower physical and cognitive capacity in at least some residents will determine clinical strategy. Different clinical strategies for people of different capacities, but it can no longer exclude residents from access to a higher level of care. And if you saw my first presentation in this series, you'll know the elephants all stand for trauma, because trauma is the elephant in just about every room that has a person in it. Here's FTAG 669. The facility must ensure that residents who are trauma survivors receive culturally competent trauma-informed care in accordance with the professional standards of care and accounting for that resident's experiences and preferences in order to eliminate or mitigate triggers that may cause re-traumatization of that resident. So let's break this down a little bit. Okay, trauma survivors receive culturally competent trauma-informed care in accordance with professional standards of practice. Professional standards of practice include using evidence-based strategies where possible, and the SAMHSA Tip 57 is really the place to start. There are very few evidence-based strategies for addressing, for mental health providers to address symptoms of trauma that are appropriate for long-term care residents who have severely diminished physical and cognitive capacities. We addressed that in the first video in this series on trauma and aging. So again, you may have people who are physically ill, maybe dying, and or cognitively challenged or impaired. Also, because the tip 57 is for behavioral health services. In medical settings, sooner or later, staff will likely have to touch that long-term care resident. And that's a big difference and one that we're going to address here. So accounting for residents' experiences and preferences. So how do you know these people's experiences? How do we find out about them? Well, SAMHSA in the Tip 57 recommends universal direct screening for history of trauma and or current symptoms. And because they're working with behavioral health clients, they use evidence, they recommend using evidence-based pencil and paper trauma history questionnaires delivered by a trained generalist. It doesn't have to be a mental health provider. Or they can have an evidence-based questionnaire asking about what symptoms of psychological trauma, delayed psychological trauma, that individual may be experiencing. Again, this works for the average behavioral health client, may not be appropriate for all long-term care residents. Please see videos 3, 5, and 6 of these series for alternate approaches to screening. And then the final piece of the FTAG is that the idea is to eliminate or mitigate triggers that may cause re-traumatization of the resident. That's the place where we're going to dig into here in this video. First, traumas are about physiology. A lot of talk about trauma triggers in politics. We're going to put that aside right now. Triggers are about physiology, as I will describe momentarily. So what's a trigger? Okay, response to psychological traumas, really intense situations or circumstances. And we talk about three different definitions of psychological trauma in that first video on trauma and aging. But response to psychological traumas take the form of one or more responses: fight, flight, or freeze. If you can't fight and you can't flee, you shut down and freeze. And these affect the full range of bodily systems. These are what adrenaline impacts. And as we all know, that affects everything. So we're talking fear and we're talking misery. On a physiological level, you see signs and symptoms everywhere. Elevated respiration, increase or decrease in heart rate, pupil dilation, pale skin, you say increase or decrease. Increase if it's fight or flight, decrease if it's freeze. Behavioral responses, impulses suggesting flight, fight, defense, running, reaction patterns, clenching muscles, tics. Cognitive responses may be increased or decreased alertness and focus. Increased if you're in fight or flight, decreased, zoning out, checking out, dissociation if you're moving into those freeze responses, if fight and flight is not going to work for you. Emotional responses, sudden intense reactions, anger, fear, panic, or the freeze responses, shutting down, withdrawal, or numbing. Drifting off, okay? So these are fight, flight, or freeze responses. These responses are involuntary. They can't be stopped, and they are so basic to survival that they cross all ages, they apply to everybody, they even cross all species. The basic concept here is that of fear conditioning. If you remember back to Psych 101, the basic example is a mouse in a cage. This mouse, the cage has a floor that can shock it, and that shock produces pain. Pain produces an unconditioned response, adrenaline, that fight, flight, freeze response, okay? It may also be playing a tone. That tone may be a little bit weird, but the mouse doesn't react much to it because it doesn't hurt. So this is the neutral stimulus. So the idea behind fear conditioning is you're pairing this neutral stimulus with an unconditioned stimulus to bring new meaning to this, to this previously harmless stimulus, okay? When the tone is played at the same time as the shock happens, the mouse brain body learns to react to that tone as if it is the stimulus, which makes it a conditioned stimulus. 2, once the mouse has been shocked in this cage, then the environment of the cage itself is scary. It's also associated with the shock and the tone. So the next time that mouse gets put in this cage, it's going to huddle down and freeze right away because it associates the cage context with the shock. So the cage also becomes a conditioned context. Moreover, when that mouse is put in the cage and a tone is played, even in the absence of a shock, the mouse will have a full body reaction as if there's a shock. Okay, so this is the conditioned response. So what happens is the mouse is now afraid of two new things: the box itself, which is the conditioned context, and the tone, which is the conditioned stimulus. Both of these are now what we call triggers. Both cause a fight, flight, freeze response. And like I said, this is involuntary. In the brain, what happens is that this shock over here, activates the neural pathways to amygdala to produce a fear response. Adrenaline release and either fight, flight, or freeze if you can't do either fight or flight. Once that tone is paired with the shock, then the auditory stimulus feeds into amygdala to activate the neural wiring to amygdala to produce a fear response. So does the box, even when no tone or shock is happening. So this wiring, the information about the shock and the tone are integrated in amygdala. And the tone and the context actually are integrated in hippocampus, but it's close by and it actually doesn't matter, but it's interesting kind of. So after this pairing, the tone alone stimulates adrenaline, fight, flight, freeze, autonomic arousal, and global bodily response. The tone now signals danger. The context does too. And this is really normal. We actually need this response to learn how to respond quickly to new dangers. So you may touch this hot stove once, but you won't touch it twice because you're going to pair red with hot, so you don't need to get burned the next time. So a trauma trigger is a normal response to an abnormal situation, like all of the things that we call traumas. And it's involuntary. It may be incomprehensible or annoying or whatever, but that's because we don't understand it. If we understand it, it helps a lot. So triggers can be nearly anything that was going on in the space around the person when that trauma occurred. So for example, say they're being raped. If they're focusing on a rock next to them on the ground, that rock may end up becoming a trauma trigger or something that looks like that rock. Triggers are multisensory. They can be something you see, something you hear, something you smell. Smells are really strong trauma triggers. Taste, touch, inner and outer physical sensations can be trauma triggered. Heat, cold, pressure, constriction, a bellyache, bowel function, memories, thoughts, images can be triggered. Emotional states like fear or helplessness, situations, being crowded, being immobilized, laying in bed when somebody's standing over you. They can be just about anything. Observing and understanding the signs and symptoms of trauma means understanding that triggers are trauma reminders that alone send the body into high alert. Bessel van der Kolk talks about trauma affecting the entire human organism, body, mind, brain. It's the body continuing to defend itself against a threat that belongs in the past. And it can be any stimulus that was paired with the trauma, whether we remember it or not. So even the individual who's reacting may not know why. So then there's both of you who are puzzled. So when you see a resident acting in a way that you don't understand, you might ask yourself, are you seeing evidence of a trauma trigger? As I discussed in the first video of this series, there are a lot of sources of trauma for older adults, including intensive medical care. And these pairings between trauma and triggers are very stable over time without trauma-specific treatment to unpair them. It can last for decades, a lifetime. So any of these things may be a trauma trigger for your long-term care resident who is acting in a way that doesn't quite make sense in the circumstances. It could be medical care, it could be loss of meaningful roles, impaired physical function, difficulty swallowing, loud noises, a physical examination, strangers looking down on you at bed, the way I described, difficult conversations about needing help with personal care, treatment planning, disease progression, hospice. It could be the process of normal life review, as I talked about in that first video, loss of privacy, sense of being under threat, being treated or talked to like a child, impairments in visual or auditory acuity. So cast a wider net of awareness, looking for clues that you may be dealing with signs of delayed reaction to trauma. So when assessing or trying to understand somebody's behavior, ask yourself these questions. Are you seeing clues that there are triggers happening here? Are you seeing symptoms of delayed reaction to trauma, also called post-traumatic stress? I talked in that first video about symptoms of delayed reaction to trauma, also known as post-traumatic stress. If you know these, you're better equipped to understand the cues that you may be seeing in your resident. I'm not going to go through them. They're available to you in that first video, and they're really important to know. So here's a figure from a chapter that Paige Hector, some colleagues, and I wrote about trauma-informed care in long-term care. It talks about using universal precautions, and the trauma-specific precautions that I'll be talking about in this slide, plus person-centered screening, person-centered trauma symptom management that can be conducted by generalist care providers, and person-centered behavioral intervention when those symptom management strategies by generalists don't work, then you pull in a mental health or behavioral health specialist with the goals of meeting person-centered trauma-informed goals of care, which are simple. You want this person to feel safe within the environment and from their own symptoms. You want to avoid re-traumatization because re-traumatization is terrifying and it feels awful. You want to help people build resilience and trust in your care. You want to help them feel empowered so they can tell you when something isn't going right. So let's talk first about universal precautions for trauma-informed care. Those are covered in more detail in the Foundation's video. But this is when you use universal precautions when you know nothing about your residents' trauma history or their triggers. These are things that you do for everybody that helps mitigate the possibility of re-traumatizing somebody. So these are the universal precautions. Trauma awareness, that means that the staff becomes aware of trauma, and they can also teach to the people who are able to learn over and over that what's a normal trauma reaction, what trauma reactions are, what's normal under the circumstance. Psychoeducation in trauma can go a long way to help easing people's distress about their own symptoms. Then there's this fostering choice and empowerment, collaboration, trustworthiness, and safety. These are called, Fallon and Harris call these the 5 pillars of trauma-informed care. Also add cultural and gender humility, creating a safe and inviting environment, and building trauma-informed organizations, because we want to take trauma-informed care of our staff as well, and our organizations. These are very general. Again, these are when the team knows nothing about person-specific, person-centered trauma history and triggers of each individual who is a resident in your facility. So a great deal of progress has been made in developing trauma-informed care of clients in behavioral health settings, and that's the tip 57. Much less progress has been made in integrating trauma-informed care into medical care and long-term care. This is despite the American Medical Association and now CMS policy supporting the integration of trauma-informed care into all medical and long-term care settings, and robust demonstration projects showing the value of doing so. We argue that the fundamental choke point in implementing trauma-informed care in medical and long-term care has been that this type of care usually requires physical touch, whereas behavioral health care usually doesn't. So why is this important? Long-term care involves medical care usually, and personal care, and this usually requires touch. More succinctly, the medical and long-term care provider often has to touch their patient to deliver care, whether that patient or resident is comfortable being touched or not. Okay, we are talking about trauma-informed procedural touch as opposed to expressive touch. Procedural touch is the purposeful physical contact that is necessary for completing a clinical task or observation. We're more often thinking about caring touch as expressive touch, touch expressing caring that is not part of medical task or procedure. But what I'm talking about right now is about what you do to touch people who have to be touched in the process of medical or personal care. We're talking about trauma-informed procedural touch for all medical patients and post-acute and long-term care residents. So this is bringing universal precautions to the bedside by bringing trauma-informed procedural touch. Because touch is really complicated. It can be scary, it can be comforting, it can be, you know, sometimes it's what we most need, sometimes it's what we least need. There's a lot of reasons that trauma-informed long-term care and medical care should include special precautions concerning touch. Physical touch, whether it is violent or not, is part of many different types of trauma and abuse. It is part of physical abuse, mugging, often part of combat trauma, although auditory sensations and sounds are often also part of combat trauma. Torture. It's estimated that more than 40% of political refugees to the United States have suffered torture. It's part of Holocaust survivorship, domestic violence, sexual abuse, sexual violence, just to name a few. Physical touch is importantly a really central element of sexual abuse and sexual violence. And both of those, as we'll see in a moment, are sufficiently common that every hospital, clinic, and nursing home is likely to have multiple female and male residents with this type of trauma history. So here's just a check, touch, check decision tree that shows how to do trauma-informed procedural touch. So you briefly describe the touch in simple everyday language before you proceed. And then you say, ready? They say yes. Then you do what you need to touch them. You check afterwards. You say, okay, if they say yes, then describe the next touch before you proceed. At any point here, you stop. If they say no, they're not ready, or no, that was not okay, then you stop, you evaluate, you provide options, and you refer when needed. This says see text, but this is in the article that we're writing about this. So what does this look like? Okay, this is just a walkthrough. It's a lot of words, but I'm going to talk you through it, of how you might do this in the long-term care setting. You can pause and do a screenshot of this in the next slide and keep it for reference. Trauma-informed touch, again, we're talking about this as a universal precaution. Really, we do think it should be for everybody. This approach involves paying particular attention to a resident's empowerment and choices during touch. It's part of developing a trustworthy and collaborative care environment that is open, nurturing, and safe for everybody. So first, you look for clues before, during, and after touching. Is somebody screaming? That's a clue. Are they fighting you? Are they crying? Are they throwing their lunch tray? Is there strained laughter? Is their speech getting rapid? Do you sense muscle tensing? Do they get sad? Do they emotionally shut down, become expressionless, quiet, maybe look to the wall, become unfocused? or a way which could indicate dissociation. Words or behaviors that could indicate fear, anger, avoidance, or an increased level of confusion, which could also be an avoidance reaction. Before you start, explain the overall procedure. Say you're going to do a wash and tell the resident why you're doing it. You use simple language. Before you start, tell the resident you're going to stop if they say so. So you might say, anything I do feels uncomfortable, let me know. I can stop or slow down. If there's not verbal capacity, say you're going to pay attention to clues that might mean stop and slow down. As you proceed, explain each step before you do it. So you've done an overall explanation. We're going to wash you up now. That's going to include, so we're going to wash you up now, and then this is particularly important for invasive and potentially uncomfortable procedures. Catheter insertion, personal care. Ask the resident if the touch you're about to do is okay before you do it, and then check in afterwards. You might say, I'm wetting this washcloth with warm water and soap. I'm going to do a wash. I'm going to wash your groin area now, your private parts. Does that sound okay? If the patient indicates yes, do it. Afterwards, you ask, how was that? Listen and watch for their response. Learn together what feels safe for this individual. This is person-centered care. Learn what doesn't feel safe to them. Ask them, what would make this process more comfortable? Provide options. There's not a verbal capacity. Look for cues for discomfort for each step. Know anything that may indicate the presence of potential triggers. Welcome that resident's questions and directions. I saw the most beautiful job of washing up with two very young care people, young women providing personal care and a wash up to a grizzled old Army veteran who had double amputation. And he directed him. He says, this is the way I like it done. And he directed them all the way through it. That was empowered. It worked really well. Everybody was really happy with it because they knew that they were doing what he wanted. Foster that. Take more time with residents who need more time. Figure it out with your supervisor if it doesn't fit into the time you have. And that's part of having a trauma-informed organization. Trauma-informed touch. It introduces choice into the care process. It gives appropriate power, which is empowerment. It's collaborative. If you follow through on what you said you would do, you'll be trustworthy. It creates safety and it promotes resilience. I should have capitalized that too. So we are suggesting that we add a sixth pillar to make trauma-informed care into trauma-informed medical care for situations in which you have to touch your resident or patient, whether they're comfortable or not with being touched. So now let's talk about trauma-specific precautions. That was universal precautions. We've added one. Okay, that's when the team knows or guesses more about the resident's trauma history. Or they're seeing behaviors that may make them suspect that there's something going on. Okay, trauma-specific precautions are when you know or suspect a resident has experienced a particular type of trauma, but you don't know enough to develop person-specific details. And I'll help you sort those two out. So trauma-specific precautions help staff be aware of any likely triggers that are specific to particular traumas. For example, military veterans may react strongly to loud noise, where sexual assault survivors may react more strongly to physical touch. Similarly, survivors of different types of natural disasters will have different types of triggers depending on the type and location of the disaster. For example, Hurricane Katrina in New Orleans as compared to the Northbridge earthquake in Los Angeles. Katrina involved heavy flooding in a hot, humid, major urban area and social mayhem among crowds packed into the Superdome. LA isn't steamy, and so there was a different feel to the disaster and a different kind of damage. It was damaged buildings and roadways, collapsed bridges. So this is kind of knowing or guessing what may be the context of what you think might have happened, or you know happened to the individual, but perhaps they can't tell you specific triggers. Okay, so first, we're going to talk about sexual violence and trauma-specific precautions you might use if you don't know person-specific precautions. We're going to talk about veterans, combat or not. We're going to talk about Holocaust survivors. I was going to include refugees, but there's not enough time, so they're off the page there. And we're going to talk at the very end about medical patients and resources for understanding some trauma-specific precautions for those folks, because that may be the most of what you have in long-term care. Okay. Different kinds of traumas have different kinds of triggers. Some of these are predictable. That's the only thing we're saying. And we can use these to help. For example, sex, okay? Sex is complicated anyway, right? All right, so sexual assault. This is a recap of a longer slide that I talked about in the first video I did on trauma and aging. More than 300,000 women and 90,000 men are raped every year in this country, according to the Department of Justice. Nearly 23 million women and 1.7 million men experience rape or attempted rape in lifetime. That's accumulating those yearly numbers into a lifetime number. About 1 in 3 women and nearly 1 in 6 men experience contact sexual violence, which is a little bit more general than rape or attempted rape. And that's by the Center for Disease Controls. You're going to have higher rates in dangerous environments. People have been incarcerated, people who've been exposed to war, people who have lived in poverty. Some events are more likely than others to cause full-blown clinical disorders such as post-traumatic stress disorder, substance use disorders, anxiety, depression. Rape is one of these. For example, being raped is more likely to cause post-traumatic stress disorder in men than any other event. For women, both rape and childhood physical abuse, interpersonal traumas, have the highest possibility of causing a trauma-related disorder like post-traumatic stress disorder, PTSD. Why is this important in long-term care? Sexual assault is common enough, as we just saw on that slide, that every long-term care facility will have multiple female and male residents who have experienced sexual violence. They will also have multiple staff who will have experienced sexual violence. This is an important thing to keep in mind, and it's part of running a trauma-informed organization. Many other residents will have experienced shame and or pain as a result of different cultural taboos regarding sex, genitalia, urinary and bowel control, and viewing and touching of breasts, bellies, thighs, and other body parts. If these were severe enough, they too might have been traumatic. And trauma does not go away just because people get older and sicker. As I said before, those pairings of the trauma and the associated context and individual triggers are very, very stable without trauma-specific treatment. So trauma does not go away just because people get older and sicker. So we said touch is complicated. Sex is even more complicated. Touching of those genitalia, backsides, breasts, bellies, and thighs may be linked to memories, as I said, of shame, blame, punishment, or coercion, even in the absence of outright sexual abuse. So can peeing and pooping be aggressive toilet training and cultural issues. So if touch is complicated, anything related to sex is even more so. I want to make it clear that using trauma-informed procedural touch, also called instrumental touch, is not the same as screening for trauma. You use trauma-informed procedural touch anytime that a caregiver has to touch a resident, whether or not you know they're a trauma survivor. And is particularly helpful with survivors of sexual abuse and sexual violence. Putting a trauma survivor in control of a potentially triggering situation reduces the potential of re-traumatization. It builds trust, it builds a sense of safety, and it can be healing in itself. In this way, every care provider has the potential to be a healer. This is the concept of giving people an appropriate level of power. No, you don't let them decide everything for themselves. You can give them this, and this is an extraordinary gift. It's also, by the way, a real gift to staff. Okay, if a resident discloses sexual assault, and this as comfort and safety are established with particular care providers, people are more likely to disclose stuff. In the middle of personal care, somebody might start talking about when somebody else touched them there, but it wasn't as nice, or, you know, it just, memories are wired to sensations. First thing you do is respond with validating language. For example, I'm really glad you told me this. It will help us take the best possible care of you. Don't try to investigate the assault or ask for details right away. You might need to do that later if it's a recent issue. Do document any reported assault and inform the clinical team. Include all known or suspected trauma triggers associated with that disclosed experience, because this is going to help that team avoid the triggers. The idea here is to provide the minimum amount of information needed to help the team provide good care. But the team needs to know. And do tell the resident that you need to let a few key staff members know about what happened so that staff can avoid doing things that raise difficult memories. Do refer to that disclosed experience in general terms. Avoid assuming about it. Avoid naming it rape and sexual assault, trauma, or abuse unless the resident defines it that way. Do tell the resident, do let the resident know that they, okay, that's worded weird. Do let the resident know that they don't need to talk about what happened if they don't want to, but they may find they do want to talk about it as time goes on. Let the resident know that there can be somebody for them to talk to, and if they're ready, that includes right away. If the resident wants to talk to somebody right away, reach out immediately to your clinical supervisor or the facility social worker on duty and follow up to make sure somebody's actually responded, because things get busy. Do uphold the resident's privacy. As with all protected health information, information about sexual assault is confidential. It may be weird and juicy, but it needs to stay confidential. And do assess current safety. Was it a recent assault or was it in the past? Do you have a resident who maybe in deeper dementia is, as happens from time to time, assaulting other residents? You need to know, so you have to assess current safety. Trauma-specific precautions for military veterans. The following material is courtesy of Dr. Kathy Bickle, associated with the Veterans Affairs Eastern Colorado Healthcare System in Denver. Okay, here's a case of Jack, and this is a fictional case and a fictional image, or a stock image. Jack is a 93-year-old World War II vet, because that generation is dying out. He's a drinker, he's a loner. He's lived in a remote cabin. He has a new stage 4 lung cancer diagnosis. Poor pain control since his lung biopsy. He's now been moved to long-term care, but he's showing nightmares, depression. He's going, what difference does anything make anyway? I'm going to die. First, we're going to look at prevalence of outright PTSD in veterans, per my initial talk on trauma and aging. What we understand is that subclinical PTSD also really affects quality of life. So this is just clinical levels of PTSD, so expand these numbers. Prevalence of PTSD in military veterans varies by service era. Vietnam War, they saw about 15% prevalence at the time of this particular study. Gulf War, we're seeing 10% in Operation Iraqi Freedom and Enduring Freedom, which is in Afghanistan. We're seeing between 10 and 15%. Notice that, we've had the Vietnam vets for long enough now that we can estimate the lifetime prevalence of outright post-traumatic stress disorder. And we see that it's quite high in this population. So if they didn't develop post-traumatic stress disorder initially, they were more likely to later, which is because prior exposure to trauma makes you vulnerable to developing full-blown trauma, full-blown PTSD the next time or two you experience bad stuff. So we don't know what the lifetime prevalence is going to be for these groups. You have other population issues. You have an aging Vietnam vet population, and that's how we have those lifetime prevalence numbers. And this notes that subclinical rates of PTSD can be higher among older adults. And that's, trauma responses are cumulative. There's this dose response, so that the more traumas you have, the more likely you are to have negative reactions to it. Okay, so particularly in military veterans, this is what's been studied. You may see avoidance and estrangement from family and others that increases with age in military veterans. Survival guilt and dissociation may decrease with age. You may see physical or cognitive decline, role transitions, death of loved ones can lead to life review, which I talk about in that first video, which can worsen later life symptoms of post-traumatic stress. Older versus younger veterans with PTSD may be more likely to report bodily complaints, problems with sleep or appetite or memory problems, rather than psychological problems like arousal, numbing, depression, hostility, or guilt. Older versus younger adults with PTSD may show increased hyperarousal. They're more jumpy. They're more likely to avoid trauma memories, and they are more likely to have sleep disturbance, but they have fewer re-experiencing symptoms like flashbacks. And dementia, it looks like it's more likely in people with a history of PTSD versus those who do not have a history of PTSD. So what might this look like in the post-acute and long-term care setting? Here's our case person. He's feeling pain from his lung cancer. He feels abandoned, he feels hopeless, and he's asking for more and more opiates and sedatives to sleep. These are negative thoughts or moods, and this is probably avoidance behavior, which go back to that, that slide of delayed reaction to traumas that I suggest you get to know real well, that I cover in that first video. Patient may feel angry about losing independence, and he may be acting out against staff, things that may seem small. But if he's carrying all these big burdens, then just littlest thing might trip him up and you get everything. And that's because there's altered levels of arousal and there's higher levels of reactivity. This guy may be seeing things, but it may be re-experiencing a prior trauma rather than psychosis. These are intrusions, and so that may be something to think about if you're seeing things that look like psychosis. Of course, then actual things like Lewy body dementia integrate really badly with re-experiencing symptoms, so you got that as well. Okay, combat trauma. The potential triggers will depend on what era and where they're deployed. It depends on the tactics that they used and the enemy used, the weapons, the terrain, the weather, and the rations they had. For example, people on the European front versus the Pacific front experienced different terrain, different things. It was jungle versus the Normandy invasion. Just very, very different circumstances. In Vietnam, some of my VA colleagues say that people are, Vietnam vets are more likely to start having trauma-related symptoms when they become incontinent. When they lose bowel control in older age associated with whatever's going on with them in older age. And apparently it's a reminder back in the jungles in Vietnam, apparently the army rations were really bad and gave them the skitters. in other words, diarrhea. And so when they start having uncontrollable diarrhea or bowel functions in later life, then they can start acting like they've been triggered. The Gulf War or the recent military actions in Afghanistan and Iraq. My understanding is for those veterans, certain types of O2 concentrators, right when they're just turned on, sound like incoming missile or mortar fire. And it freaks people out. So potential triggers will depend on what era and where deployed. If you can talk to people about kind of at least where you know they were and what situations, you may have a better sense of what you see people reacting to. There's other types of military trauma. Just because somebody wasn't in combat does not necessarily mean they don't have a military-related trauma. Military sexual assault, about 1 in 3 women, some say 1 in 4. Female veterans report an attempted or completed sexual assault during military service, whether they were deployed or not. There are still much larger numbers of men being treated in the VA for MSA or military sexual assault compared to women, simply because there's so many more men than women in the service. Again, don't assume that some won't have military related trauma because they didn't see combat. If you've heard of military atomic veterans, there were military personnel between the, I think the time was 1940 and 1979, where military veterans were either accidentally or on purpose exposed to atomic testing in Utah, testing in the South, atom bomb testing in the South Pacific at Bikini Atoll, in the military occupation of Japan at Nagasaki and Hiroshima, in radiation experiments on humans, looking for what the health effects of radiation were when it was so new. But then a lot of those atomic veterans are having those reactions, those health responses now. It wasn't until 1996 that US Congress repealed the Nuclear Radiation Security Agreement Act, which made atomic veterans keep an oath of secrecy about being exposed to radiation. And many died never knowing, never telling anybody. The VA now reports that there were also thousands of defense-affiliated programs that used human test subjects between 1940 and 1974. Mustard gas exposure, radiation exposure, nerve agents, psychochemicals like LSD, irritants, exposure to diseases, to name a few. And sometimes this was where conscientious objectors went during their military service. Trauma-specific precautions for Holocaust survivors. Holocaust survivors are people who lived in one of the countries that was occupied or under the influence of the Nazi regimes between 1993 and 1945. So this is now pretty much the ones that are left with children who are hiding in people's walls and basements and stuff. But survivors may have experienced uprooting, deportation. They or their families may have been in labor and or extermination camps, living under, or they may have been living under false identities and hiding or perpetually on the run. The Holocaust is defined as the persecution and murder of European Jewry under the Nazis, beginning in, again, 1993, but peaking during World War II, 1939 to 45. Simple facts can help you identify a Holocaust survivor without directly asking. Clues are going to be date of birth, place of birth, date of immigration, their religion, the languages they speak. Indications that a person is a Holocaust survivor may include accented English, European languages spoken, lack of any family members of the same generation, because so many families were utterly wiped out. A number or tattoo on the arm. They will be old, and they may well be unwilling to discuss their past or share personal or medical information. Potential triggers. A number were sealed in and died in and had their families and colleagues die in ghettos. A ghetto was a sealed and fenced or walled-in area of a city where Jews were confined under overcrowded and very unsanitary conditions. In the camps, they were locked or guarded in areas to which they'd been transported, typically by railroad train. They were separated from their family, imprisoned. Inmates were stripped, shaved, deloused, denied privacy, tattooed, beaten, pushed, starved. So all of anything about that can be an issue. Guards, dogs, alarms, loudspeakers, or loud voices. In the labor camps, inmates were used as slave labor till they died. Concentration camps, people were starved to death, used in medical experiments and or killed. In death or extermination camps, they were set up to systematically just exterminate all of the inmates, and they were either gassed in communal showers or burned in furnaces. In Israel, which has a large proportion of Holocaust survivors, nursing homes have special precautions for taking survivors to showers that are unfamiliar, because it can be very, very distressing. By the end of the war, most camps have become death camps, so this would apply overall. I recommend Caring for Holocaust Survivors by the NJS Society. Here's where you can get that. That's updated, but it's a really good resource. Importantly, for clinical care, the APA recently excluded, in the Diagnostic and Statistical Manual of Disorders, 5th edition, excluded nonviolent death and life-threatening illness from their definition of trauma, which excluded 60% of cases from a formal diagnosis of post-traumatic stress disorder. But these patients still suffer clinically significant trauma-related symptoms that can impact their medical care and their quality of life. This is why a broader view is required when assessing and addressing trauma in medical settings. What the NCI, the National Cancer Institute, says is, a timely and careful assessment of patients with cancer is critical to identify the symptoms of cancer-related post-traumatic stress, to note the deleterious impact of the symptoms on functioning, and to plan interventions targeted at the most distressing symptoms. This is a book by Michelle Hall and her husband Scott Hall on managing the psychological impact of medical trauma. It is very good, and I recommend it to you. Person-specific precautions. That's when you know this person's clinically relevant trauma triggers, okay? That's what we're going for. When you can, move past guessing, connect with your residents, learn their individual histories and trauma triggers so that you can best collaborate with them, empower them, provide them with choice and a voice in their care, in what scares them, so that you and your facility can be seen as safe and trustworthy. Because there's many different stories as there are people. In the first video of this series, I talked about Anid, who had mid-to-late Alzheimer's. Her language is deteriorating and she's become combative during personal care. We talked about, this has been an issue. She's been fine with her caregivers before, but now she seems mad. They did a medical check, very important if you see behavioral changes, but no obvious physical cause for the behavioral changes. Turns out the caregiver was whistling, and the staff reached out, which was brilliant, to the family to see if whistling might be triggering. An older daughter reported that she wouldn't have disclosed it without being asked, reported that Anid had been molested by an uncle as a young girl, and he whistled when he was doing it. Anid's usual coping skills were declining as her dementia progressed, and now a man entering her darkened room while she's laying in bed is frighteningly familiar. It's one of those triggers, and it's re-traumatizing. She was accidentally being re-traumatized, and she was fighting back accordingly. The solution here was to avoid the trigger. They could identify it, they could avoid it. Caregiver stopped whistling, adopted a quieter approach, and they eased back into a positive relationship. The solution here was to ask the right questions so the staff could avoid the triggers so she isn't repeatedly being terrified by her own care. So here's Esther. Esther's in long-term care. She's got COPD. She uses her wheelchair. She stopped sleeping at night. So she's not participating in stuff during the day because she's all tired. She's taking naps. No significant dementia, so it's not sundowning. Did a medical check. Nothing showed up, but she's recently become incontinent. It's not that unusual, but staff are getting frustrated. Late at night, in talking with somebody she trusted, Esther said she'd been thinking a lot about a puppy she had as a little girl. But he peed on the floor one too many times, and her mom told her dad to take it out and shoot it, which he did. She loved that puppy. Anyway, trauma does not go away just because we get older. These, by the way, are true stories. Names have been changed, photographs have been changed. Esther was staying up all night to be sure she'd use the bathroom properly. It wasn't working well, and she was getting more anxious. This is something for staff. Just knowing about the puppy help the staff think more productively about ways to help. The facility's consulting behavioral health specialist, who's there because of phase 2 of the CMS Final Rule, supported the staff in helping Esther understand her own trauma responses. They could not avoid or remove the trigger. It was just a natural consequence of the fact that she was getting towards the end of life, but they could help her cope with it and accept it. They also helped her grieve the loss of her puppy for the first time, and she slowly returned to sleeping at night. We can't erase the past, but we can learn to be comfortable, more comfortable with it, to get along and even thrive. Here's a guy with his elephant at a bar. Remember, we're taking this elephant to represent trauma in these slides. He's aware of his elephant. He's attending to it. He's even taking good care of it. He's saying, oh, and can I have some peanuts for my elephant? That's the idea here, to understand the trauma and the triggers to the extent possible so everybody can relax and just have a better time. Thank you for sharing your time with me. Here's my contact information. Here's how you get hold of the Ithaca College Gerontology Institute. Here's a little bit more about me. This material has been brought to you through a grant from the Care Compass Network in collaboration with the Ithaca College Finger Lakes Geriatric Education Center and also, to some extent, the National Center for PTSD. Thank you again. Stay safe, be well, and take care.